Hi friends, in this video of ECG basics, today I will talk about bifascicular block. First is the disclaimer. Caring Docs YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only. It should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or a company. The diagnostic criteria for bifascicular block is it should meet one of the two ECG pattern. There should be right bundle branch block with left anterior fascicular block, which is manifested as left axis deviation, and RBB and left posterior fascicular block manifested as right axis deviation in the absence of other cause. Some authors they describe left bundle branch block as a bifascicular block as it may indicate left anterior fascicular block plus left posterior fascicular block. However, clinically the term bifascicular block is reserved for a right bundle branch block with either left anterior fascicular block or left posterior fascicular block. Coming to electrophysiology of bifascicular block, it involves the conduction delay below the AV node in two of the three fascicles. The conduction to the ventricle is by the single remaining fascicle. The ECG will show typical features of right bundle branch block plus either left or right axis deviation. The right bundle branch block and left anterior fascicular block is most common of the two pattern, and this is due to single coronary artery blood supply, that is left anterior descending to the anterior fascicle. The right bundle branch block and left posterior fascicular block is less common due to dual blood supply, that is right and left circumflex arteries, and this combination may be associated with more extensive underlying cardiac pathology. Typically the bifascicular block pattern, here we can see the right bundle branch block combined with left anterior fascicular block, and it is manifested as left anterior descending artery supply. The clinical significance of the bifascicular block is it is often associated with structural heart disease in 50 to 80% of the patient, and it is extensive fibrosis of the conductive system. There is a risk of progression to complete heart block with additional damage to the third remaining fascicle. However, the clinical context is very important. Overall rate of progression to complete heart block is 1 to 4% per year, and in symptoms-free patient, these figures are almost 1% per year. Patient presenting with syncope, they have 70% of annual risk of progression. Syncope or pre-syncope in the context of bifascicular block is an indication for admission and monitoring. If other causes of syncope are not identified on workup, the pacemaker insertion is recommended. The main causes of bifascicular block are similar to those of right bundle branch block and left anterior fascicular or left posterior fascicular block, and the causes are ischemic heart disease in 40 to 60% of the cases, structural heart disease in 50 to 80%, aortic stenosis, anterior MI, Lenné-Lev disease, congenital heart disease, hyperkalemia, and a new onset bifascicular block in the context of chest pain is highly associated with proximal LAD occlusion, even the absence of ST segment changes. In 30% of the cases, patient present with no ST elevation and bifascicular block is the only acute ECG findings. The differential diagnoses are masquerading bundle branch block representing or presents with a mixed complete RBB and complete LBB pattern similar to a typical bifascicular block pattern. This rare ECG pattern indicates more extensive fibrosis of the conductive system, and limited studies demonstrate a poor prognosis and higher progression to complete heart block. In patients with RBB, the right axis deviation indicating left posterior fascicular block may be due to either other causes such as right ventricular hypertrophy, and these need to be excluded before ECG is labeled as a bifascicular block. So in this ECG we can see a right bundle branch block In precordial leads with RSR dash complex in V1 to V2 and prominent LED indicating LED's left axis deviation indicating left anterior fascicular block. The right bundle branch block with left anterior fascicular block in the context of chest pain. Here we can see the right bundle branch block, that is RSR dash pattern in V1 and V2, V3 and slurred S wave in the lateral leads. And there are concordant ST segment changes best seen in V2 and hyperacute T waves inferiorly. This patient was found to have 99% of the proximal left anterior descending artery occlusion, and here we can see right bundle branch block with left posterior fascicular block, RBB with wide QRS, slurred S wave in lead 1 and slurred R in V1. Right axis deviation with dominant positive deflection in AVF along with RS pattern in lead 1 and QR pattern in lead 3 and AVF, suggesting left posterior fascicular block. Here we can see in the CG right bundle branch block with left posterior fascicular block and right axis deviation. The best way to live your life is to dedicate it to something you believe in for the betterment of the society. It was said by Dr. Devi Shetty. With this, I conclude my today's topic. Thank you. Keep learning.